Hello everyone in Newcastle and everyone on the internet. It's great to welcome Celeste Porsbjerg back to Newcastle. Celeste is going to speak to us about non-eosinophilic asthma, and if you have questions, we'll have time for questions at the end. So if you're listening on the webinar and you have a question, if you type your question in the question pane on the screen, then Steve Maltby will help facilitate those questions getting answered at the end. So a bit about Celeste. So Celeste is a respiratory specialist and a clinical research associate professor at Bispebjerg Hospital in Copenhagen and a member of the University of Copenhagen. She's done some amazing work on asthma and airways disease that spans epidemiology and clinical research, and she's now focusing on severe asthma, pathophysiology of severe asthma, and starting to think about severe asthma registries. And what she's chosen to talk about today is a topic that's close to our hearts here in Newcastle, non-eosinophilic asthma. Common but poorly understood. Thanks, Celeste.
So thank you very much, and thank you for this opportunity to give a presentation here in Australia. I am usually so fortunate as to come out here once a year. Normally I arrive at the airport and I come out here 2 days later and I'm terribly jet lagged. In Denmark it's 3 a.m. in the morning, so my PhD students probably won't be watching this, although I have tried to suggest it. This time I had a week's vacation before coming out here with my husband, so it's been really lovely being back in Newcastle and being with this fantastic research group again. So the topic of non-eosinophilic asthma, I certainly thought that it was a topic that would interest you, but it's also a topic that I really think needs more focus and is being a little bit forgotten these days because we have all the biologicals coming on board. Some disclosures first, and then just a little bit about where I'm from. So as Peter said, I'm from Denmark, the capital of Denmark, which is Copenhagen. It's the north of Europe. And you can see the picture here of our hospital, which is an old and beautiful one. It covers all of inner city Copenhagen, but we also have a severe asthma clinic, so 1/3 of our patients get referred from outside. So it's in some ways similar to your clinic here, but I also think as an urban population, it's in many ways quite different. Now, the topics of this talk, I'll be saying something about the prevalence of non-eosinophilic asthma, the potential mechanisms, the response to anti-inflammatory treatment. We can talk about what is the best treatment strategy. Do we need to know more about that? And finally, I'll touch upon some potential novel mechanisms of how ICS might work in non-eosinophilic asthma. So the definition of asthma, clearly it has the 2 key defining features of a patient having symptoms combined with variable airflow limitation. However, as part of the definition of asthma, it's always been, in most guidelines, included that it's usually a condition characterized by chronic airway inflammation. And as you know here, inflammation can be tested by looking at the number of granulocytes in the airways, and it can be split into overall groups of eosinophilic and non-eosinophilic asthma. And when we look at the prevalence of those inflammatory phenotypes, if you like, this is a population of severe asthma patients from Belgium. So it's quite a large population. And this is a cross-sectional picture of what's going on. So it's really just what's happening on that day. But as you can see, more than half of the patients do not have eosinophils in their airways when they're tested. Now, obviously, eosinophils will respond to treatment, so they will be affected by whether the patient is on treatment or not. But if you look at patients over time, and you see here on the left side patients who are followed over time without any ICS, so this is not severe asthma, it's milder asthma, you can see here that approximately half of the patients are persistently non-eosinophilic. So you test them, you retest them, you never find any eosinophils. So that's quite a lot of patients. Looking at those who are treated with steroids, obviously the group is going to become larger because you have reduced their eosinophilic inflammation. And as I was saying, I think one challenge in this area, or call it challenge, is a good thing for patients, but in terms of treatment, the focus is really currently on Th2 pathways, because that's the pathways we know about and we understand, and most biological drugs in the pipeline target these pathways. So we have anti-IL-5, where mepolizumab has been recently approved, and reslizumab, and we have anti-IL-4 and IL-13, and even blockers of Th2 and blockers higher up in the system of TSLP. However, trying to block pathways leading to non-eosinophilic types of asthma has proven less successful. You can reduce the neutrophilic inflammation, but it doesn't really seem to have that much impact on the clinical outcomes. And also, additionally to that, you can say that neutrophilic asthma is out there, but the largest group of non-eosinophilic asthma have no granulocytes. So we don't really know what's going on with these patients, and we don't really know how to target them from an immunological point of view. And now, potential factors that might be involved in the development of non-Th2 asthma. This is a paper by Sally Wenzel, and this is really very theoretical. There's not a lot of evidence to support what is going on. The airway microbiome is one thing that might act to alter the innate immune response. And we have looked a little bit at the airway microbiome, and it's a difficult topic to look at because you get a very diverse signal where you don't really know what it tells you, but you can look at whether patients group together. And what we saw was that patients who are eosinophil low seem to cluster, and they have more Neisseria, they have more bacteroidetes, but what that means, we don't know. However, when you look at those who have neutrophilic inflammation, yes or no, there's really no clear clustering there. So it doesn't seem that an altered microbiome in non-eosinophilic asthma is something that's related to neutrophilic inflammation per se. So we don't know. We don't understand what it's doing. We don't know whether it's cause, whether it's effect. Another potential pathway is that there are some murine studies that suggest that Th1 and Th17 cells may induce what you could call a Th2-like response via the release of interferon gamma, which can attract mast cells to smooth muscle cells in the airways and could induce airway hyperresponsiveness. Certainly, it has been shown that when you look at patients without any signs of eosinophilia in the airways, they have increased mast cells within the smooth airway muscles. So something is going on that looks like what you would normally perceive as a Th2-related response. We looked at a population in Copenhagen of all patients coming through our clinic over a 12-month period. And we looked at their hyperresponsiveness to mannitol and their level of pheno and their eosinophils in the airways. And what we saw was that half of those who responded to mannitol in the uncontrolled group were low in pheno and had no eosinophils. So this is saying there's quite a big proportion of patients out there who have hyperresponsiveness to an indirect stimulus, which we normally say requires inflammation, but we can't see any eosinophils. So we don't know what's going on there. It could be mast cells. So non-eosinophilic asthma responds less to ICS. This is eosinophilic asthma on the right and non-eosinophilic asthma on the left. And you can see the eosinophilic group, they really, after being treated with inhaled steroids, they really decrease in their hyperresponsiveness, whereas they almost worsen with the placebo. Whereas the non-eosinophilic group, it's a pattern that goes all over the place. It's not clear whether they're responders or not. Another study, I believe from New Zealand, where they compared eosinophilic and non-eosinophilic asthma. And what you see is that there is a decrease in airway hyperresponsiveness. So there is probably some response in these patients. It's just that it's less, and we don't understand what the mechanism of it is. Here's a study where patients first received inhaled steroids and oral steroids, and then after that were tested with a bronchodilator. And what you see here is that the non-eosinophilic group do not improve in their lung function, whereas the persistently eosinophilic group improve. However, when you then give them bronchodilator, the non-eosinophilic group is able to increase further. In other words, you can't improve their lung function with an anti-inflammatory drug, but if you give them something that relaxes the smooth airway muscle, they have the capacity to increase in lung function. So we can do something for them. It just looks like it would need to be a bronchodilator. So the question, I think, really is, how do we treat non-eosinophilic asthma best? It's not addressed in the guidelines, even though this is a large group. And if we look at the GINA guidelines, if we have someone who's on low-dose ICS and they're uncontrolled and we want to step them up, we have a choice between increasing ICS or adding LABA. And is that the best option for everyone, or is that different between eosinophilic and non-eosinophilic asthma? We don't know, because no one has studied that. Or at least no one has studied that prospectively. But here in Newcastle, you've done excellent work. You've done the MAP study of pregnant women with asthma, and you're all well aware of this study, which showed that you can reduce exacerbations with a pheno-based strategy. So it's essentially a management strategy which looks at, does the patient have inflammation or not? And so Vanessa and Peter did a post hoc analysis of this and presented it at the ATS last year, because what was interesting to look at was what happens with those who have low pheno, so the non-eosinophilic group. Because when you look at the algorithm, what's really happening in this study is that if you're in the pheno arm and your pheno is high, you get more ICS. But if your pheno is low, so you're probably non-eosinophilic, you get more LABA. Whereas if you're in the control group, what happens if you're poorly controlled is, at least to start with, you're increased in ICS, and then LABA is added. So it's sort of like comparing the adding a LABA versus increasing the ICS. So it turned out, when looking at the data, that over half of the women had non-eosinophilic asthma, defined as low blood eosinophils and low pheno. So that's the majority of these women. And looking at what treatment they ended up having, the pheno arm was increased in LABA, whereas the clinical arm was unchanged in LABA use. And you can see here the effect on exacerbations, that there was quite a profound effect on exacerbations in this group with non-eosinophilic asthma. In other words, early addition of LABA in non-eosinophilic asthma seems effective in reducing exacerbations. And importantly, all of these exacerbations were non-eosinophilic, so they were patients who came in with an exacerbation and had a low pheno. So the question is adding a long-acting bronchodilator, it could be a LABA, it could be a LAMA if the patient is already on a LABA. Is that a better strategy in non-eosinophilic asthma compared to increasing ICS? And I personally think that that would be a very interesting question to address, and which probably could be addressed looking at the old phase 3 approval studies for things like Symbicort and Serotype. So probably the data is out there somewhere. Now, to finish off a little bit about potential other mechanisms. As I was saying before, non-eosinophilic asthma does respond to ICS, and what could be the potential mechanisms behind that? Clearly, it could be a reduction of mast cells that has been shown in studies where ICS has been increased sufficiently for that to happen, but there could also be other things happening. We've been interested in the role of the ion transport. It's really our electrical signal system in the cells, and interesting to keep in mind when we look at inflammatory pathways. The sodium-potassium ATPase, or pump, is a vital central part of all of our cells. But what it does specifically in relation to smooth muscle cells is that it contributes to the reduction of intracellular calcium via the sodium-calcium antiport. And that results in a reduction of intracellular calcium, which leads to smooth muscle relaxation. So we were curious to see how this could have a role, and looking at the literature, what is interesting from a respiratory physician's point of view is that the long-term regulation of the sodium-potassium pump number is regulated by a number of things, but one of them is adrenal steroids. So if you give a patient steroids, they will increase their number of sodium-potassium pumps. And the other thing is that the acute activation of these pumps, you can do that with a beta-2 agonist. So people who work with sodium-potassium pumps and how they work physiologically, they will use salbutamol as a classic stimulant of this pump. So we were curious to see what happens when you inhale steroids, what happens to your sodium-potassium pump contact, because that has not been examined before. So we looked at a group of healthy individuals and we gave them 2 weeks of budesonide, 1600 micrograms daily, and we took a muscle biopsy from the thigh, because you need quite a large biopsy, before and after. And what we saw was a 17% increase in the content of sodium-potassium pumps. So as a clinician, I thought it was interesting that 2 weeks of a standard high but still standard dose of ICS has such a large systemic effect. And we looked at what the correlation with the level of budesonide in the blood was compared to the sodium-potassium content. And you can see here, the higher your plasma budesonide, the higher your sodium-potassium pump content was. So that was like a preliminary pilot study to see what's going on. And the next study that we're just commencing is doing a bronchoscopy study, because obviously we need to know what happens in the smooth muscles down in the airways. And we will be studying 50 steroid-naive patients before and after 8 weeks of inhaled budesonide, to see whether there's an association between the change in the sodium-potassium pump and airway hyperresponsiveness. So these patients will be included on the basis of a positive mannitol test. So to conclude, non-eosinophilic asthma seems to be at least as common as eosinophilic asthma, but most novel treatment mainly target eosinophilic asthma. The mechanism and hence potential treatment targeted non-eosinophilic asthma are still poorly understood. Question is whether addition of long-acting bronchodilators, be it LABA or LAMA, to ICS should be the first choice if you meet a patient in the clinic with, say, low pheno and poor symptom control. And the question is also, the effects that we do see of ICS in non-eosinophilic asthma, is that related to non-inflammatory mechanisms of action that we haven't really thought about yet? And finally, obviously, there's a need for more studies in this group of patients. So thank you for your attention.
Thanks, Celeste. Any questions? John?
The first one, because you live close to Sweden, Shell Alvin says that he's written one review that I know of where he said that don't confuse a high NO with their eosinophily of the shore. in that the mechanisms are associated, but I'm not dependent on them. So in your data, have you seen evidence where you see eosinophilia in the sputum, you might see a low? Because this becomes important to be able to try to find out in the clinic.
Yeah.
Just repeat the question.
So the question from John Brennan was whether we see patients who have a separation between having increased FeNO or low FeNO and then having eosinophils in your airway. So in other words, is FeNO always an indicator of airway eosinophilia? And no, it certainly doesn't seem to be. It's associated mechanisms, and FeNO is driven by IL-13 and eosinophils are driven by IL-5, and theoretically you could have patients who had a separation in whether they have an activation in that. We have looked at that from the map-out population, that if you have an activation of both, so you have both a high FeNO and eosinophils, you will have overall more hyperresponsiveness. You will simply be more ill. But from a clinical perspective, you do see patients on high doses of ICS who have a suppressed FeNO, and then when you do sputum, they will have massive eosinophilia. So there's obviously some sort of split, but that's again within what I would perceive as an eosinophilic type of asthma, or a type 2 asthma, if you like.
Do you ever see high FeNO non-eosinophilic asthma?
I think that's rare. So patients with a high FeNO but normal eosinophils, I think that's less common. So it would more be the other way round, I think. On the other hand, I think it depends on the level of FeNO. If patients are within the group who have a very high FeNO, so above 50 or even more, they probably have eosinophilic asthma. In the intermediate group, there are so many other causes driving FeNO that I think it tells you a different story. So it's the same marker. It's like looking at CRP. It can tell you about infection when it's really high, but in lower levels it tells you about systemic inflammation, or it could tell you about a connective tissue disease or something like that. So I think with FeNO, it's important not to think about it as one continuous biomarker. There's probably patients with classic severe eosinophilic asthma who always have a very high FeNO, and they're typical when you see them, if you look at them in the clinic in data sets. And then there's a large group of patients with mild asthma, and when they're untreated, their FeNO is elevated, and you treat them and it's suppressed very quickly. And they are thankful to treat. Whereas the ones with a very high FeNO and severe asthma, you can get their FeNO a little bit down, and their sputum eosinophils, you can get them a little bit down with steroids, but they don't disappear completely. And what's driving that is certainly of a very big interest, because we don't understand that. They seem to respond well to anti-IL-5. It just quickly reduces their eosinophils. But that's something I think the severe asthma registries will really be important in giving us some information on what happens with these different groups of patients with severe asthma, if you like.
So that was excellent. I was just wondering, is there any evidence about a difference in the prognosis for the development of irreversible airways obstruction between eosinophilic and non-eosinophilic asthma, given the belief that reduction of inflammation should potentially reduce that chance?
So eosinophilia is a risk factor for losing lung function, but I think what becomes, and non-eosinophilic asthma will also tend to have a lower lung function, or at least the neutrophilic asthma. What's confusing in that is two things. I think with the eosinophils, similar to what I was saying with FeNO, patients with a late onset severe eosinophilic asthma, you will often see them come to clinic with a poor lung function. They really get hit hard on their lung function. At least when they have exacerbations, it really reduces. But if you take someone who has early onset allergic asthma and have eosinophils, I don't think their eosinophilia is necessarily a predictor of loss of lung function. So I think the remodeling story, it's not necessarily that, you know, eosinophils are always a signal of a specific mechanism happening. It could be a split signal. And then, of course, the other thing being, I think, with the neutrophil story, that we don't know enough about the cause and effect there. We don't know whether those you see with neutrophilic asthma, they have the neutrophils because the lung function is low, or vice versa. So, yes.
Peter?
Thanks, Celeste. Great talk, right? I assume you'll be on the screen, actually, so I'm pleased to see you.
It's good to see you too, Peter. 3 a.m. in the morning, I'm live.
So the Danes are clearly very stoked to have those muscle biopsies done. But there's a lot about some other ways of measuring, I'm not sure the Australians.
Yeah, no.
Measuring changes in sodium.
Yeah. We are doing that. The reason why we did the skeletal muscle biopsies is because the method that we want to apply is urbane binding. So it's a radioactive marker that blocks the sodium-potassium pumps. And it's a very, very good lab method. It has a standard deviation that's tiny. So you can show alterations like that in 10 subjects. Now, you need a certain amount of tissue. So what do you do there? It's an interesting question, because we need to have biopsies that are at least 5 milligrams or something like that. And with a forceps biopsy, you would not necessarily get that, and it would be a mix of epithelium, etc. So what we have just completed is a pilot study where we use cryobiopsies. And cryobiopsies is a technique that has been developed for interstitial lung disease. So you do a transbronchial biopsy. But what we found was that you can take a mucosa biopsy. So a cryobiopsy is really just a probe that's frozen around -70, and you put it down the scope and you hold it for 1-2 seconds against the side of the airway wall, and you come away with what's really a part of the airway wall of the mucosa, which provides for a lot of interesting things, I think, research-wise. The biopsy is approximately 10 to 20 times as large as a forceps biopsy, and it contains a lot of smooth muscle. So we've just done a pilot with 10 subjects in that, and it looks like it's going to be the technique that we'll be using in this study. And that will also mean that we don't need to do the skeletal muscle biopsies, because it's really not the muscle tissue that we're interested in. So that was just the beginning of it. So.
Transforming fibroblasts into muscle cells. Think of doing that.
Well,
You take fibroblasts and then biopsy and transform them into smooth muscle.
So transforming fibroblasts into smooth muscle. So to examine this in vitro, you mean? Well, there's a lot of studies that's been done in vitro on the role of the sodium-potassium pump and adding steroids and adding lava. So in vitro, we do see an effect. It's just never been studied in vivo. So that's why we wanted to have a look at this. And you can, of course, say, what are the implications other than it's just another potential mechanism of asthma? Or of,
what would be the clinical implications of massively ramping up those pumps?
I think, we don't know whether the right way to go with non-eosinophilic asthma is that they need more steroids. I mean, do you really, clinically, if you see a patient who's on a low-dose ICS, what do? Do you put on a lab, or do you increase ICS? Because there's also arguments to say that you should increase ICS. Ian Pavor's EOS study, which was really a study about comparing, I think, the SMART Symbicort strategy to standard ICS, they did a bronchoscopy in that study. And what was the sub-finding, but it was interesting, was that when you looked at the mast cells, it was only in the group who had a high dose of ICS that effectively had a reduction of those mast cells. And that didn't happen in the Symbicort arm. So we don't know. It may be that the right answer for non-eosinophilic asthma could be more ICS. However, the MAP study suggests something else. But so it's a good question.
Positive. mannitol and even low dose ICS, you just need to get them to take it.
So if you're positive to mannitol,
so these non-eosinophilic group that have got a positive response to mannitol,
yeah.
the one thing that's clear is that they will actually do extremely well on a low dose, just because you take the regular and do the clinical improvement and not the airway responsiveness present. I'm not too sure that applies to all your non-eosinophilic group. But that might be something.
So the comment from John Brannan was that if you have someone who's hyper-responsive to mannitol, you really just need to give them a little bit of ICS and make sure that they take it, and then it will improve. And I think you're right. I mean,
so that there's a real strong responsiveness to stuff that it takes 6 months or more to lose their responsiveness.
yes.
Whereas the milder group only takes.
I think that's probably true, and we also have some observational data to suggest that, but it's just really not been studied. And there is a real need for RCTs in this area, and there might also be a difference between being someone who's not on steroids and mannitol responsive, and then some of the patients we see who are on steroids and are still responsive, and they may be different in terms of what that's telling us.
Yes.
Celeste, great talk. I was curious about the microbiome data you showed. It seemed like all the difference within these, not so much in the neutrophilic group. Did you see any bacteria in the neutrophilic?
Did we see, sorry?
Did you see, like we often see them, of course, for example, in the neutrophilic group, but it didn't seem like you saw big changes in that group.
No, I mean, so the question is that regarding the microbiome data, that you here often see things like Haemophilus in patients with neutrophilic inflammation, and did we see the same? And no, we didn't really. I mean, the take-home message was that, because you can do these various comparisons and say eosinophilic asthma compared to healthy, neutrophil compared to healthy, neutrophil compared to eosinophils. And overall what we saw was that from a microbiome point of view, eosinophilic asthma looks just like healthy, but non-eosinophilic asthma looks different. But then when you go further into that and say, what about neutrophilic asthma? It doesn't have any characteristics. So I can't say that we did see that. This was a group of mild asthmatics who were, at the time where they had the bronchoscopy, were not on ICS. So you could say on the one hand, they might not be representative. On the other hand, you don't have the effect of ICS, which would probably do a lot to alter your airway microbiome, I would expect. So. But it's something that probably needs more work done, because there is some microbiome data out there, but not that much connecting it to airway immunology. So probably an important next step.
So the non-eosinophilic group were different. There were no specific species differences? Was it diversity?
They had more Neisseria, but they also had more Bacteroidetes. When you work with the microbiome, you find out there are bacteria that you, as a clinician, have no idea about. Bacteroidetes seems to be, if anything, probably the healthy microbiome. So and the Neisseria is where you would find things, I think, like Haemophilus, actually. So it's a signal that goes in two directions, and it's really a bit like saying, okay, so one group is purple and the other is green, but what's purple, what's green? So we're finding it difficult to get our head around what this really means, and I think people working with the microbiome are becoming increasingly pragmatic to say probably it's better to look at large populations, split them into responders and non-responders, and then go back and say, do they differ in terms of the microbiome? At least that's what's been successful in other disease categories, such as inflammatory bowel disease and things like that. So it becomes very pragmatic. You sort of imagine that you'll end up having a list of bacteria, and you do to a certain level, but it's a very, very, very long list. So
we might stop there. So thanks, Celeste, for a great talk.
Thank you.